Welcome to the Practicing Clinicians Exchange podcast on ASCO conference coverage. This podcast will highlight late-breaking and important new and promising data in the management of mantle cell lymphoma. I am Amy Goodrich, a nurse practitioner at the Johns Hopkins Kimmel Cancer Center in Baltimore, Maryland. I will be your moderator for today's episode. Joining us today is Dr. Tycel Phillips, Clinical Associate Professor and Medical Oncologist at the Rogel Cancer Center at the University of Michigan in Ann Arbor, Michigan. This program is supported by an educational grant from Pharmacyclics LLC, an AbbVie company, and Janssen Biotech, Inc., administered by Janssen Scientific Affairs LLC. This program is provided by Practicing Clinicians Exchange for 0.5 ANCC and AAPA credits, with 0.5 credits applicable for pharmacology credit for NPs. To receive credit for this program, go to pce.is/MCL. The learning objectives for today's podcast are to identify recent practice-changing data in the management of mantle cell lymphoma and to describe strategies for management and monitoring of patients with mantle cell based on the most current efficacy and safety data. We will be discussing 5 trials during this podcast. We will be talking about the SHINE study, which is a double-blinded, placebo-controlled phase 3 study of ibrutinib in combination with bendamustine and rituximab, with rituximab maintenance in first-line treatment for older patients with mantle cell. We will be talking about updated 3-year follow-up data from ZUMA-2 using Kite X19 in relapsed refractory mantle cell. And then we'll be talking about 3 early phase studies, a phase 1/2 of zilovertamab and ibrutinib in mantle cell and CLL. We'll be talking about 2 first-in-human early phase studies, one an ROR-RR1 targeting bispecific that is showing efficacy in relapsed refractory mantle cell and CLL, as well as another first-in-human trial of NX-2127, which is a first-in-class BTK degrader with IMiD-like activity in a host of relapsed or refractory B-cell lymphomas. Dr. Phillips, could you please tell us about the SHINE study, which evaluated ibrutinib in combination with BR in the first-line setting?
Correct. So thank you for the introduction. So the SHINE study was our first sort of introduction to in a randomized phase 3 study of looking at incorporating the oral BTK inhibitor ibrutinib into frontline therapy. So this study randomized patients to a arm of bendamustine rituximab times 6 cycles with continuous ibrutinib at 560 milligrams daily versus bendamustine rituximab again times 6 cycles plus placebo. After the completion of induction, all patients entered into rituximab maintenance, which was given every 8 weeks for 12 cycles. The bigger difference being, again, in the experimental arm, ibrutinib was continued daily until progressive disease. And in the control arm, patients continued on a placebo until progressive disease. The primary endpoint of the study was progression-free survival in the intent to treat population. Because of the bendamustine rituximab backbone, this was previously untreated mantle cell lymphoma patients who were 65 years of age or older, who had stage 2 to 4 disease. The study itself enrolled 523 patients in a 1-to-1 randomization. So looking at the study, it was designed obviously to see if we could improve upon what was considered to be our standard of care at the time, bendamustine rituximab in elderly unfit patients. I'll bet that's a bit of a controversial statement given that we don't really truly have a standard of care in any MCL, whether they were unfit older patients or young fit patients. But based on the BRIGHT study and the ROMO study, it did appear that bendamustine rituximab was a less intense regimen for elderly patients compared to our trial. So with this study, the goal obviously was to improve on the progression-free survival based on the indication of ibrutinib in second-line setting being such an effective therapy. You know, always the need and want is to move these more effective treatments up in the line of therapy to see if we can improve upon outcomes in the patient population. So with this study, which was presented at ASCO, what we saw was that there was a significant progression-free survival benefit in the experimental arm. So in the ibrutinib bendamustine rituximab arm, there was a PFS of around 6.7 years versus a PFS of 4.4 years in the placebo arm. And the authors commented on a 25% reduction in risk of progressive disease or death in the experimental arm. So on the surface, just sort of looking at that information, it would appear that we would have a new standard of care with bendamustine, rituximab, and ibrutinib for elderly patients. But I think as time has gone on since this study was open, enrolled, and produced a final result, treatment has become a bit more nuanced as we've got more and more information about the durability of response of BTK inhibitors in a second-line setting. So, with that, I think if we look at the study as a nutshell, I don't think it's as impactful as it probably would have been several years ago, based on some of the result findings, what we know about BTK inhibitors in a second-line setting, and, some of the concerns that came out of the study regarding toxicity in the patient population.
Well, great. So I think I hear you saying that you're not considering this data practice changing at this point, given the other options that we've got for these patients. Is that correct?
I would say so. I think if they could go back, I'm sure the sponsor of the study would, work to design this study in a different way of evaluating maybe a third arm of sequentially giving these agents, because the biggest catch point we have here is that the control arm had a PFS of 4.4 years. If we look at some of the historical data of what we see with BTK inhibitors in a second-line setting, especially in patients who obtain complete remission, that can tackle at least potentially another 5 years of remission. So if you do an apples to orange comparison of what the BR plus ibrutinib arm is, plus what you could get with sequentially giving these agents, you're looking at 7.7 years versus potentially up to 9 years without the added toxicity that comes when you combine agents. So the toxicity profile of the combination did indicate that there appeared to be a higher risk of complications in the experimental arm compared to the placebo arm. And as well, there are a higher number of deaths that need to be explained in the experimental arm compared to the placebo arm that were not attributable to progressive disease. So with that, again, I would say it's probably not going to be practice changing. I do think some clinicians will use the combination in select patients. Identifying who those patients are may be a bit difficult just because some of the higher risk patient populations that we get concerned about, such as high risk MIPI, blastoid pleomorphic, P53 mutated patients, those patients did not necessarily seem to obtain a substantial benefit from combinational therapy. So identifying who are the right patients to give this combination to up front will probably take a bit more time if this combination actually gets a designation within the NCCN guidelines or gets FDA approval.
Right. And so other than the death, can you just talk a little about other adverse events? In case folks are going to see this coming to their infusion chairs or to their clinics, so folks are ready.
Right. So surprisingly, neutropenia was fairly consistent between the two. Diarrhea and nausea. There was more rash in the experimental arm, which is to somewhat be expected. Oddly enough, I would say there was more thrombocytopenia in the experimental arm, but it appeared to be a higher percentage of higher grade thrombocytopenia in the placebo arm, which is a bit, unexpected. Higher grade 3-4 anemia, higher incidence of upper respiratory infections, at least grade 3 to 4 in the experimental arm. So I think these are the things that would need to be looked at. So, and it really, I think the key point here, obviously, is, with long-term use of ibrutinib, obviously we know the chronicity of some issues that come up, including, myalgias, cardiac issues, and things of that nature, which, obviously wouldn't necessarily come up in some of the common treatment emergent events that were demonstrated. Now, some of the things we do know with BTK inhibitor, there was high incidence of bleeding in the combination arm, 43% versus 21.5%. Higher incidence in major bleeding, even though not substantial, 5.8 versus 4.2. AFib was higher, which would be expected at almost 14% more versus 6.5%. Hypertension, especially grade 3 to 4 hypertension, 8.5% versus 5.8. Then arthralgias wasn't necessarily very different, but the grade 3 to 4 was 1.2% versus 0. So, these are sort of the nuanced things that, need to be pulled out. And also when you think about, now in the COVID era, how with this combination with bendamustine being very efficient at depleting T cells and obviously ibrutinib inhibiting function of B cells, how this will play out now that COVID is a part of our lives moving forward. How do you sort of, look at these situations? How would these numbers be a bit different, knowing the type of environment we're in right now?
Right. Well, thank you. That was a great overview. So let's move on to the 3-year follow-up from ZUMA-2. Can you comment on these longer-term outcomes and whether this data will impact your practice in any way?
So just to give some background, ZUMA-2 was obviously the study of brexucabtagene autoleucel, which is a CAR T product, which was evaluated in patients with relapsed refractory mantle cell lymphoma. So prior to this, outcomes in ibrutinib or BTK refractory MCL was very poor, and we really did not have any sort of treatment modality that showed any substantial benefit or duration of response. So the initial study results from this study, which indicated an overall response rate of 91%, was amazing in this patient population compared to something we had necessarily not seen before. So with this, the initial concern, obviously, with CAR T products, besides cost, is obviously durability of response to justify the amount of money that goes into this treatment modality. So long-term follow-up for all these CAR T products will be very important. So what this long-term follow-up did, it obviously gave us a greater glimpse of how long and durable these responses are. And so from this, if we look at survival, which is an important modality in post-BTK setting, what they saw from all patients was a median overall survival of 46.6 months, with a 30-month overall survival rate of about 60.3. Patients with complete remission, which is always important to remember with CAR T, they had a median overall survival that was not reached, and a 30-month overall survival rate of 76.1. Patients with partial responses, overall survival of 16.3 months, and patients with no response had an overall survival of 8.5 months. So what this indicated is at least that patients who had a complete remission, majority of those patients maintained that remission and obviously had a very improved overall survival compared to what we saw with historical controls. So if we look at the progression-free survival for this patient population, we see a median PFS in this patient population of 25.8 months. And again, consistent with what we see with overall survival, patients who had a complete remission obviously ended up with a much longer progression-free survival. And we have a progression-free survival of 48 months in those who got a CR and a 24-month PFS rate of 71.8. And we see decreasing returns based on, decreasing response. Partial response, 3.1 months with a 24-month PFS rate of 18.8. And obviously patients with no response obviously did not do very well. And the duration of response in patients with CR/PR was 28.2 months, those with a CR 46.7 months. And we still see with these high-risk patient populations, we still don't necessarily see any substantial change in patients with some high-risk features such as p53 blast or pleomorphic. One other nuance that they discuss is that if they were able to obtain a minimal residual disease undetectable state, meaning they look for, DNA evidence of the cancer within the peripheral blood at a very high sensitivity, which is a little bit more of a sensitive modality than what we have with sort of typical radiographic imaging, such as PET scans, CT scans. They did indicate that patients who are MRD undetectable obviously had a much longer duration of response, progression-free survival, and overall survival, compared to those who may have had a radiographic response but still were MRD detectable, meaning they still detected evidence of the disease on this molecular test. So very early as far as MRD testing and where we are in mantle cell lymphoma, but I will say it's encouraging overall that some of these patients are still having durability of responses. These patients will continue to be followed out for a longer period of time, and we'll sort of look and see how these things will play out long-term and where CAR T sort of fits as we have this very early evolving field with these post-BTK patients.
And does this change how you think about this therapy for mantle cell? And I guess what I'm wondering is, will you choose patients differently based on this data? So, for example, if someone doesn't get the greatest response or they've got a lot of disease going into this modality, does that change how you think about patients?
Yeah, so in two ways. One thing that they noticed is that, as we mentioned in the prior discussion about the SHINE study, bendamustine and its impact on T cells and CAR T, it did appear that patients who received CAR T within 6 months of exposure to bendamustine had worse outcomes than patients who had received bendamustine greater than 6 months prior to CAR T. So that's one thing to keep in mind as you transition these patients to CAR T and what you use sort of as far as sequencing. The other thing, obviously, in this situation is that we basically creating a new patient population. So I think CAR T, if patients have accessibility and meet criteria and approval, I think should be something as of right now should be considered the standard for patients who are in a post-BTK setting, unless you have a very, good alternative, and which are mostly only available in clinical trials or which not universally available. What it sort of created now for us is a post-CAR T patient population. For those who don't respond to CAR T or have a partial response to CAR T, where do we take these patients next? So I don't think we have a lot of real world data to figure out where we take these patients after CAR T if they don't get a durable response. And that'll be something that needs to be sort of figured out as we move forward, as we sort of, from probably a fair number of these patients, we're kicking the can down the road and just delaying, the shoe dropping with CAR T. As we're going to capture everybody.
Right. We've been talking about therapies that are familiar to us. And so this is sort of a perfect segue into our newer trials. So let's start with our phase 1/2 zilovertamab and ibrutinib in mantle cell or CLL. What are your thoughts about this regimen and its safety and efficacy?
Yeah, so I will say, just starting off, since it's a phase 1 study, safety wise, I don't think there were any alarming real safety signals with zilovertamab, which is just a naked ROR1 antibody. The key point being ROR1 is highly expressed on B cell malignancies and not necessarily expressed on sort of normal human cells. So it allows us to target this very similar to what we do with some other sort of targeted agents that are very utilized in these lymphoid malignancies. So in this study, obviously, they evaluate the safety of zilovertamab plus ibrutinib in MCL, CLL, and a part 1, like a dose finding, and then expansion cohorts in MCL and CLL as well. So what we saw safety-wise, we saw fatigue, we saw diarrhea, some nausea, cough, dizziness, nothing that is necessarily inconsistent with what we've seen before, especially with just BTK inhibitor alone studies. I will say, as far as treatment emergent adverse events, that really we need to pay attention to. There was some reports of confusion and some musculoskeletal issues that came out in the experimental arm that wasn't necessarily seen in ibrutinib alone. That's one thing. Efficacy-wise, it did appear that the combination of zilovertamab plus ibrutinib improved outcomes compared to what we saw with ibrutinib alone. So if we look at mantle cell lymphoma specifically, and what we look at sort of response rates, so even though small numbers, so I will put that out there because there was only 27 MCL patients treated overall. But if you look at patients with high Ki67, prior BTK exposure, prior autologous stem cell transplantation, CAR T exposure, bulky disease, P53 mutated, and sort of heavily pretreated patients, you see very impressive overall response rates across the board, ranging from 100% to 75% in this patient population. So if we look at complete remissions, which are always important in these combinations, the complete remission rate, I'll bet, was a bit lower, obviously, in the P53 mutated patients. So I don't think this combination is going to be what sort of tips the scales in P53 mutated MCL patients. So that still is an need area that we need further treatments to look into. But in patients with heavily pretreated and, prior CAR T, prior BTK, I think the complete remission rate was acceptable. And with the safety profile that we have, that this obviously warrants further exploration in patients with mantle cell lymphoma. Now, the question will be, if this does move forward, where will this fit in? Is this something that we can, come back to and resalvage these patients if they had prior BTK treatment and were relapsed on the BTK or became refractory to a single agent BTK? Or how does this compare with, if we have a new standard of care with the ongoing simpatico study was looking at, ibrutinib and venetoclax in a second line. If that turns out to be a positive study, we'll have a new benchmark which to compare everything else that tries to combine with the BTK inhibitor. So it'll be interesting to see where these things play out, where these drugs sort of fit in at, and where we move going forward. Whether it's a triplet in the second line, zilovertamab, ibrutinib, and venetoclax, or any BTK inhibitor and venetoclax, or if this drug is combined with something else, post-CAR T that is not a BTK inhibitor. So these are things that we need to look at as we move forward, and as this combination gets more maturation in MCL.
Right. Okay. So more to come on zilovertamab. So our next study is another ROR1. This is a bispecific NVG-111, also a phase 1 study. What are your thoughts on these data that were presented at ASCO?
Very preliminary. I think they had a total of 5 to 6 patients. Only one patient had mantle cell lymphoma. I will say the challenge I see with this treatment moving forward is it is a continuous infusion, which is very similar to blinatumomab. And, outside of ALL, blinatumomab has not really taken off in lymphoid malignancies because it's not very appealing to have a continuous infusion. And most of the other bispecifics, which are, again, are CD20, CD3s, are, they are given either weekly or every 3 weeks. So that is the sort of the market that this drug is sort of moving into and will have to compete against. And so unless there's a substantial benefit to this bispecific, I having a very hard time competing with the ones that have a much better sort of infusion schedule compared to a continuous infusion. That being said, obviously, if the sort of mode of administration is improved or somehow, you can have some space and is not required to be a continuous infusion, I think, again, as I mentioned with the last drug, it's still a very attractive target. And to have another sort of bispecific that doesn't necessarily go after CD20 or something that goes after CD19 would open up another window for us. As you know, sometimes our lymphoid malignancies will lose markers as they try to evade treatments that we implement. So it's not uncommon, maybe not mantle cell lymphoma, but we do see in DLBCL, which probably has a wider use of sort of these T-cell targeted therapies, loss of CD19 or loss of CD20. So if ROR1 becomes a viable target and they can figure out a better way to give this treatment, then I think this can be something that can be explored moving forward. But as it stands now as a continuous infusion, I'd be very hard pressed to sort of think that this, is the route to go forward for this treatment.
Yeah, I agree. But again, targeting ROR1 and just, more and more agents targeting that pathway. So considering these emerging therapies or combinations in early development, where do you see their potential roles? Do you think any of these could add to the landscape at this point?
So if we look at these experimental agents, I do think zilovertamab is likely to have a role. Just where it fits will be up for debate, whether you combine it with a BTK inhibitor, or maybe this is something you combine with lenalidomide, given it's an antibody therapy. Bispecific T-cell engager, I think, as we discussed before, I really think unless the mode of administration is improved, I don't know if there's a role for that. But we'll have to wait and see, and obviously see how efficacy plays out with this agent, because if very efficacious, and always will find a way forward, no matter how onerous the administration schedule is. So I think other ones we've had, I think zilovertamab is the only one that we can probably pinpoint somewhere either second line or after CAR T. The other ones we'll have to take a wait and see approach.
Right. All right. Well, thank you so much for listening today. We hope you enjoyed this. Again, please visit pce.is/MCL to take the post-test and claim your credit for this activity. A slide set, including the studies we discussed, will be available online for download.